this point of time, we'll wait for a few minutes for some more people to join in. And for this session, we have two speakers with us. And the first speaker for the session will be Dr. Nancy Sahni. She is the Chief Dietitian and Head at the Department of Dietetics at PGI-MER Chandigarh. She had received her doctorate from PGI Chandigarh, is a registered dietitian and a certified diabetic educator, as well as having interest in pediatric oncology with a total experience of more than 20 years. She has several papers, presentations, and awards to her credit, and is also the guide and co-guide of various MSc, MS, DM, PhD theses and projects. So that is the first speaker for the day, and the second speaker for the day will be Divya Mahajan. Divya is a dietitian at, hi Divya, and hi Dr. Nancy. So Divya is a BSc in dietetics and a postgraduate diploma in nutrition and dietetics, and has several years, more than 7 years of experience working with children with cancer at the PGI Pediatric Hematology and Oncology Department. So I will hand the session over to you, Dr. Nancy. So please start, and I request everybody to stay muted in between the session, and please post queries on the chat box, and be looking forward to an interactive session with you all. And it's great to see so much of attendance despite the India-Bangladesh match going on. So over to you, Dr. Nancy.
Yeah, thank you, Dr. Richa. I'll share my screen. This is coming host disabled participant screen
Yes,
share.
ma'am. I'm just giving you the access. Yeah,
Okay.
it's done, ma'am. Now you can share, please.
Can you see the screen?
Yes, we can see it absolutely in the slideshow mode.
Okay, thank you. So I'll be talking on nutritional interventions in pediatric oncology. Thank you, the organizers, for inviting me over for this talk. So I hope we have discussion on this, and we learn from each other. So to introduce pediatric malnutrition, it is an imbalance between nutrient requirement and intake, resulting in deficits of energy, protein, or micronutrients. So the macronutrients are energy and protein, and micronutrients means vitamins and minerals that negatively affect growth, development, and other outcomes. Now, eating the right kind of diet before, during, and after cancer treatment helps in tolerating the treatment modalities and maintains optimum nutritional status. So nutrition is a backbone everywhere, but when the things are compromised, our body has all these challenges to face, it becomes a backbone. A healthy diet includes eating and drinking enough of the foods and liquids that have important nutrients. Now, if we talk about the antioxidants, a well-balanced diet that includes an array of antioxidants from food sources alone may confer a benefit from infections and mucositis during treatment of childhood ALL. So all these antioxidants from food sources, not from supplements. Now, it is associated with reduced rates of infection or mucositis with no increased risk of relapse or reduced survival. Now, lower intakes of antioxidants are associated with increase in the adverse side effects of chemotherapy. Now, one thing is clear: if macronutrients are optimum, the micronutrients usually fall in place. So if the micronutrients are not optimum, that means the macronutrients are also not optimum. Prenatal vitamin supplementation, so it goes before the child is born. Prenatal means vitamin supplementation, especially folic acid, during times of conception and fetal development have been evaluated by various studies, and it has been shown that it has a protective effect against so many types of cancers. The disturbances in the methylation of imprinted genes can predispose individuals to cancer, including pediatric cancers. Dietary factors which modify DNA methylation include selenium, vitamin A, vitamin B12, thiamine, vitamin B6, and zinc. And all these will be in place when all the macronutrients, the energy and protein is in place. There are over 30,000 bioactive food components in fruits and vegetables, which may affect a variety of cancer processes. Now, what are the clinical implications of poor nutrition? Whether it is undernutrition or overnutrition, both have negative effects. Now, it affects the pharmacokinetics and pharmacodynamics of several of the drugs that are utilized in the treatment of pediatric malignancies at both ends of the spectrum of malnutrition, that is overnutrition or undernutrition. So PEM and being underweight and stunted and being overweight or obese. So it may affect or influence how the drugs are cleared. So this has been well described for methotrexate, when undernutrition decreases drug clearance and is associated with the increased toxicity. Obesity also affects quite a number of drug clearances. So PEM is also associated with increased infection rate and diminished quality of life. So obesity, a diagnosis of AML, is associated with increased risk of death from side effects, and during treatment, it is associated with increased risk for relapse and increased side effects of chemotherapy. So when to intervene is a big question कि कब हमें nutrition का intervention शुरू करना चाहिए. So at baseline, it's very important overview of common nutritional concerns, complications, basic nutrition education, possible interventions during treatment, because कहते हैं जब नींव strong है तो आगे building भी strong होगी. So सबसे ज़्यादा the focus should be at baseline, because it's difficult to take the U-turns rather than take a road ahead should be clear. If the child is having mild PEM, so of course, intervention, dietary counseling might be oral supplementation. They can be kitchen-based or they can be commercial. Then moderate PEM, oral supplementation, of course, is required. Might be nutritional support is required, EN, or if it is indicated and necessary. And severe PEM, of course, nutritional support will be required. So these are the general guidelines. One needs to work with an interdisciplinary team of doctors and nurses and paramedical staff and everyone. So then come to a consensus. Now, type of nutritional therapy in cancer patients. Number one is diet counseling. So, there are changes in the eating habits, avoiding defined foods during radiotherapy, appetizing preparation of food, mechanical softening or blending of diet. So it is required. All this is required. So, there's depression setting in. Might be kids don't have much, but the parents have this, the family has, so they definitely, they have it, the vibes go. Now, drug treatment, of course, it is required anti-emetic agents before, during the treatments to avoid aversions. And then nutritional supplements, as I already mentioned, they can be kitchen-based, home-based, or they can be commercial. Then enteral nutrition can be gastric or duodenal, and parenteral nutrition can be peripheral or central vein, depending upon the condition. Now, if we see the recommended dietary allowances for Indians from NIM, which were revised in 2020. Now, if you see, like infants and from 0 to 11 months, it is around about 550 to 670 kilocalories. So it is according to the weight of the child, 80 to 100 kilocalories per kg body weight. Then children like 1 to 3 years are bracketed at around about 1000 kilocalories, and 4 to 6 years around about 13 to 1400 kilocalories, 7 to 9 years about 1700 kilocalories, and 10 to 12 years, boys and girls, varies from 2000 to 2200 kilocalories. Now, if the child, for example, बच्चा अगर 10 साल का है और उसको 30 किलो या 32 किलो का होना चाहिए, but वो 20 किलो का है, so then you have to strike a balance. Sorry. So, if the child is 20 kgs, but the child is not 6-year-old, the child is 10-year-old. So what you're going to do is, might be we start off with this type of calories, 1300, 1400, 1500, then we see how the child is taking, and then we go to the recommended dietary allowances of 2000 kilocalories. So this is how we have to work up and see these things. Now, this is a tolerable upper limit for all the nutrients. Like protein, it says for the children and this thing that it should be less than 15% of the total kilocalories. And then these micronutrients, all this is given. So these are the safe limits which the child can have. And it is same for the normal as well as for the patients who have this cancer. Now, if you talk about pediatric nutritional screening and assessment, in a tertiary care hospital like in PGI with huge volume and limited resources, screening tools can be very useful since the patients with high risk of malnutrition prioritized and proactive intervention protocol can be for them for positive medical outcome. So assessment is a dynamic process and it is required a diagnosis during therapy and survivorship to evaluate child's nutritional status and adequacy of intake to allow for appropriate timely intervention. So अगर पहले ही पकड़ा जाए बच्चे को before कि वो बहुत ज़्यादा the things are out of control and then we are heading for tube feeds and whatnot. So it's better that baseline assessment and this pediatric screening tool, the screening tools come handy in such situations. Now, nutritional screening tool for childhood cancer, this is one is SCAN. So it has to be specific to the disease status, type of cancer, stage of cancer, its treatment, clinical symptoms, so that you can see if the child is at risk of malnutrition or he or she is already malnourished. So keeping these guidelines in mind, the nutrition screening tool for childhood cancer was developed to identify childhood cancer patients. Now, if you see these questions, does the patient have a high risk cancer? Is the patient undergoing intensive treatment, or has the patient had poor intake over the past week? Has the patient had any weight loss over the past month? So if the score is more than equivalent to 3, then it is the child is at risk of malnutrition. So he or she can be referred to the dietitian for further assessment. And what is the reason for all this? And if you see the pediatric nutritional assessment after screening, it is always A, B, C, D for everything. So A means anthropometry, weight for age, height for age, BMI for age, MUAC. So because weight cannot be a reliable indicator in this setting, so arm anthropometry is recommended. So biochemical parameters like all the serum values. So one must consider lab values in context to overall clinical picture. So clinical assessment, like the reasons for depleted muscle and fat stores and micronutrient deficiencies, you have to review the GI concerns, whether the child is having nausea, vomiting, or diarrhea, or constipation, or pain while eating, appetite, hunger loss. So all these things. And of course, dietary history. It is a baseline evaluation, should include dietary history because we have to see how much macro and micronutrients are going in the child, and are there any food aversions or allergies or intolerances, or are the baseline eating patterns were already faulty? Might be बच्चा जो है घर में पहले ही faulty situations हैं जब वो ठीक भी था, या परिवार में awareness ही नहीं है कि कैसे combinations of nutrients लेने चाहिए. So patterns, home patterns. So all these are very important. And sometimes there are some alternative therapies which the parents or people at home, some Ayurvedic things they go into, and then they stop certain nutrients to be given to the child. कि ये नहीं देना, वो नहीं देना, इससे ज़्यादा हो जाएगा. So that also has to be assessed, that whether it is that is it a food aversion or बच्चा खा नहीं पा रहा है, या कोई GI problem है, या वहम है. So this is very important. So the basic goal of nutrition support in children with cancer is to sustain and promote normal growth. This is very important. Reverse malnutrition if present, prevent future malnutrition, promote normal eating behavior, improve quality of life. So this work this is possible only and only if a multidisciplinary care team is there. Again, alone a doctor, alone a dietitian, alone a nurse, alone a paramedical staff can never do it. So it has to be a team effort always. So challenges in delivering optimum nutrition, it's very easy to say things in theory कि ये दो वो दो ऐसे दो वैसे दो, but इतने challenges होते हैं practically हम जब बच्चों को देखते हैं कि the way they cannot eat and why they are not eating. So let's discuss some of these. So common side effects everybody is aware, caused by cancer treatment because of chemotherapies or radiation or any steroid therapy. So, there are frequent bouts of nausea, taste change, dry mouth, diarrhea, constipation, mucositis. As steroids, they can increase appetite, sometimes cravings for unusual foods. Children admitted for longer time, they develop a sort of aversion to hospital food trolley. वो देखते सारी वो कहते हैं हमें नहीं चाहिए खाना, हमने नहीं खाना. So growing children, high nutritional needs per kg of body weight and lower reserves. एक तो बच्चा ग्रो भी कर रहा है, ऊपर से खा नहीं रहा, lower reserve और हो जा रहा है. Adults में of course they're not growing, so this is a positive thing. So what happens is that weight loss, even a small amount, can be significant in proportion to their size. Like a 1 kg weight loss in a child weighing 10 kgs is equivalent to a 10% weight loss in their body weight. It amounts to quite a lot. So how to, face all these challenges? Like if there is anorexia and one knows as a doctor or a dietitian that yes, it's going to happen because the child is subjected to such type of treatment. So you have to plan ahead. Every bite counts. Strive to eat 1/3 calories and protein in breakfast, small, frequent, high-calorie meals, supplements, suck on lemon or hard candy. Maintain good oral hygiene is very, very important to maintain good oral hygiene. And you have to see that, उस time पे क्या होता है? You don't have to run after the conventional foods of dal, roti, sabzi. You have to see how to pack up these nutrients in a smaller package, in a tastier version. In a version the child is going to take it. So, nutrition is an art and a science. Nausea and vomiting, small, frequent, bland meals, cold foods are well recommended. Avoid strong flavors, supplements, anti-nausea or anti-emetic medicines are given. It's like a pregnant female. जैसी घर पे तड़का लगता है उल्टी आ जाती. Same way, बच्चे के सामने जैसी दाल या रोटी की खुशबू आती उसको might be he feels nauseated. So cold foods are tolerated in such things like,
Nancy, Dr. Nancy, sorry to interrupt, but I think a lot of people may not understand Hindi completely. So,
okay, so I'll continue in English.
Yeah, there are people from all over the country
Okay.
in the session. Yeah, please.
So,
Thank you.
No problem. I'll continue in English. So small, frequent, bland meals, cold foods. Like for example, when in pregnancy, I believe most of the females must have encountered this nausea thing. The minute you have the smell of any food being made in kitchen, smoke in oil and all that, so one feels nauseated. So similarly, the same feelings do occur by these kids. So what happens is the cold foods are tolerated better, what we have seen, like puddings and custards. So these are tolerated better. Now, feeding difficulties from like alterations in brain or GI tract. So altered textures are required. Soft, pureed foods, wide bore straws, they are required. So wide bore straws, why the wide bore straws? Because when you are giving a shake or something like that, so maybe I'm adding a cereal in it, I'm adding a fruit in it, I'm adding some protein supplement in it, I'm adding curd or milk in it. So it requires the viscosity increases. So wide bore straws are required for that. For diarrhea, avoid hot, spicy, high fiber, fatty, greasy foods. Avoid caffeine. Use caution with milk. Aim for soluble fibers. Increase amount of sodium and potassium, because of course diarrhea will wipe out all the electrolytes. So sodium, potassium we have to see. Then constipation, maybe we increase the amount of fiber or laxatives or adequate fluid. So to see according to the situation of the patient, we decide. Mucositis, again, try soft pureed foods, non-irritating foods, eat cold or room temperature foods. They will be non-irritating. Avoid dry, coarse or raw foods. Say no to condiments and spicy foods. Try to maximize calories and protein with nutritional shakes. As I already mentioned, you have to give good huge amounts in small packages and small frequent meals. You cannot expect a child to finish it up in one go, and it should not be done also. It should not be forced. Then hyperglycemia, obesity, of course, wellness clinic and balanced diet, all these things are required. So these are the certain. This is the booklet we have in our hospital setup. So we give it in Hindi and English to the patients, that how to combat diarrhea, vomiting, like the way I explained. So this is all written. Try, cool liquids and buttermilk and small frequent meals. And we've also given homemade formula for making ORS. So we have given, and even the foods which can be given if the child is having loose stools. So all this is there. So if we talk about neutropenic precautions, everybody is well aware of what are the neutropenic precautions. They are the steps you can take to prevent infections if there is a moderate to severe neutropenia, which is a condition that causes low neutrophils in blood. So neutrophils are the type of white blood cells that help your body fight infection and bacteria. So food safety is paramount in this. The immune system, because it is compromised, so making the body more susceptible to illnesses. So basic guidelines which we follow is avoid raw or rare meat and fish and uncooked or undercooked eggs. Cook meat until it's well done. So please, here the point is, never tell a person or a child or the parents not to give non-veg. They can give, but it should be well done, well cooked, and they should not experiment with the new meats. Like if the child has not had lamb meat or fish, and you give it when the child is sick, so it should not be done like that. Thoroughly cook eggs, no runny yolks, and avoid foods containing raw eggs such as raw cookie dough or homemade mayonnaise, because homemade mayonnaise we put raw egg in it. Avoid unpasteurized beverages such as fruit juices, milk, and raw milk yogurt. Consume only pasteurized milk, yogurt, cheese, and other dairy products. Avoid raw sprouts. So sprouts have always to be in a cooked form. Thoroughly wash fresh fruits and vegetables before peeling. So you wash them, peel them, maybe wash them again, and then give them. So that is very important. And the fruits should be fresh. They should not be raw. They should not be stale. This is very important to see. Now, oral route is the best route. So oral supplement is indicated, our supplements are indicated when you see because of course oral route has to be the first approach in improving nutritional status. So when we see that there is a complementation of oral intake, why it is required to improve the calorie and protein recommendations. The usual diet is not giving it. The usual meal pattern is not sufficient because the child is eating less. There is a version. So you have to chip in the oral supplements, which can be homemade or commercial. And if the impeding treatment will adversely affect nutritional status and ability to meet needs orally, you know that what the road lies ahead. You are well aware that the child's appetite will be low. So you have to just buckle up the things. So oral things can be like homemade. From the various regions of the country, different foods are made. Like in Punjab, here in Chandigarh and this Punjab area, this rice kheer, sago kheer, panjiri is like, this is roasted gram flour and roasted wheat flour with maybe nuts, roasted and powdered nuts, and maybe skim milk powder. And this is poha and upma with roasted nuts and with cheese chunks in it. So all these things can be made, and the oral meals can be supplemented with all these things. And of course the commercial supplements, various commercial supplements are required. With the guidance of the doctors and the dietitians, they can be incorporated to enhance the kitchen based feeds. For example, if you're making pudding, so you can add oral supplement in it to further enhance its protein and energy value. So if we talk about RUTF, ready to use therapeutic food, in Africa, it has been used to combat SAM, it can be used for cancer patients also. So this makes it a practical solution where cooking facilities and fuel are limited. It has a long shelf life. It's safe to use even in the absence of clean drinking water. And children without medical complications can be cured right in their homes and communities. Like, it is a supplement. Basically, it is a protein and energy supplement. So how it works? Community health workers are trained in early detection to recognize cases of severe acute malnutrition. So health workers learn to recognize medical complications. Early detection, early treatment, it is always better. So the cons are it may replace nutritional traditional practices. Like there are different traditional practices in every home. Like I already mentioned some of them. In Punjab, we make pinnis and panjiris and laddus. And similarly, there are so many things in South and West and East and West. So so might be it replaces those traditional practices. And might be that when the RUTF is stopped, children often slip back to malnutrition. So maybe the cost factor. So there are, or maybe sometimes the RUTF itself is too heavy that the children do not tend to eat anything else, which which is also not a good thing. So, but all said and done, there are so many RUTFs made, like homemade supplements in India. If you see Karnataka, West Bengal, so it's Devanagari mix or Shakti Nutri mix. So all these, the basic thing is that they have some amount of, cereal, some amount of peanuts, some amount of these pulses or lentils. They have jaggery. So it gives approximately they are giving one helping is giving around about 350 to 400 kilocalories, 15 to 20 grams of protein. It's a good amount. Like 100 grams give not help one helping, 100 grams gives such amount. So it's a good nutritional supplement. Similarly, West Bengal and Maharashtra and Kerala, Andhra Pradesh, Tamil Nadu, they have this Nutri-Mix, Lapsi, and Sattu mix, all these things, Sattu Mawa, high calorie cereal mix. So, these all can be used for such patients. So here in our hospital, we give 3 types of diet plans. One is dietary tips for cancer patients, whatever I told in my slides, that at the baseline, then how to manage diarrhea, loose stools, how to give cold foods, the big bore straws and everything. So everything is mentioned in that, the general guidelines. Then soft diet, pureed diet foods, when the child is suffering from maybe mucositis or anything else. And then maintenance diet chart. Sometimes children, increase, they become overweight. So to prevent both under and overweight, so these maintenance diet chart plans are given, in the OPD setup. So take-home message for oral nutritionists provide advice on energy-dense foods, how to increase calories using high-fat, high-calorie foods, provide advice on age-appropriate dietary supplements, which will vary depending upon local provision, continue to monitor intake and weight, agree cut-off weight for progressing to enteral feeding if change in nutritional status. As I already said that if the gut works, use it. Exhaust all oral diet methods first. Divya is going to give you a beautiful this case study presentations on all this. So that will be explained very nicely. So indications for EN, for enteral nutrition is for tube feed is malnourished patient expected to be unable to eat more than 5 to 7 days, or normally nourished patient expected to be unable to eat more than 7 to 9 days. Inadequate oral intake resulting in deterioration of nutrition status or delayed recovery from illness. More than 5% weight loss from usual weight or during therapy. Then meeting less than 80% of estimated nutritional needs through oral intake plus impending treatment will adversely affect the nutritional status and ability to meet needs orally. Malabsorption. So all these, all these or some of these can be indications for tube feed. Some of the tube feeds made in PGI, we make it out of skim milk powder and oil and sugar and some cereals, like there is a suji kheer, there's a rice gruel if it is made out of rice, and there's enriched milk. Then there is a A1 and A2 feed, it is from soya based feeds. So different types of feeds are being made in house over here, kitchen based. For if the child is suffering. If the child is a SAM child, so admission, it is always small amounts, eat 2, 3, or 4 hours day and night, vomiting, reduce the amount given at each feed and double between feeds. And 80 to 100 kilocalories per kg per day at initial phase. These are the two types of feeds which we give, and F100, F75 is like the initial phase, and catch-up phase is F100. So Divya is definitely going to give you a more insight into the through her case study presentations. This is just one slide for PN. When the child is unable to ingest, digest, or absorb oral enteral nutrition due to gut dysfunction, we definitely have to go in for PN. So if there's intestinal obstruction, or there's an intracerebral vomiting, diarrhea, severe mucositis, acute hemorrhage, severe pancreatitis, radiation enteritis, short bowel syndrome, so start ASAP, continue till GI tract is fully functional. So, and monitoring for compliance is very important, related to central venous access or glucose levels, electrolyte and mineral levels, hepatic or gallbladder effect, volume or lipid emulsions. If stable, blood tests can be done less often, and nutritional assessment every 2 weeks. So to summarize, it's I'll just give a table to summarize. Now, who is at nutritional risk? We will start from here. Patients with high risk diagnosis, patients with suboptimal or no oral intake, patients who are underweight or have had significant weight loss. It can be less than 5 percentile weight to height or BMI, and or more than or equivalent to 5% weight loss over 1 month for normal or underweight patients, more than equivalent to 10% weight loss over 1 month for overweight patients. Okay. Now the next question is, does the GI tract work? If the answer is yes, of course, oral supplements. We improve the oral intake, then continue the oral supplementation. If no improvement in intake is 50% of the usual for 3 days, then if the platelets are okay, then we go to the EN support. Order nutritional consult, short term less than 6 weeks, NG if no aspiration, NJ if there is an aspiration risk, and if it is long term more than 6 week high risk disease, consider G tube or J tube. And if signs and symptoms of tube feed intolerance is there, then hold the feed for 2 hours and return to previous rate tolerated. Optimize antiemetics and evaluate dosing and timing of other meals. And if the question here, if the GI tract is not working, if it is no, then of course we go in for TPN, order nutrition consult. So what are the TPN criteria? I already told you in the previous slide. Severe nausea, vomiting, grade 2 more than grade 2 mucositis, or all these things, radiation enteritis, SBO, bowel surgery, and also whatever I discussed in the previous slide. So this is the general algorithm. Of course, the things vary practically, but this is generally what we can do. So it is always a teamwork. Thank you.
Thank you very much, Dr. Nancy, for this extensive overview of nutrition and pediatric oncology. I think we'll start with the second talk by Divya, who will be doing primarily a case presentation on how things evolve for a child on treatment for leukemia. And in the meantime, if there are any questions, please either raise hands or post the questions in the chat box. Comments, questions are very welcome. So thank you, Dr. Nancy, and please stay around so that you can answer questions later on. And over to Divya now. So
yeah, ma'am, please, can I get the access for screen sharing?
Yes, it's given, ma'am.
Okay, thank you so much. I'll just get back. So is it visible to everyone?
yes, Divya, your slides are visible, but they're not in the slideshow mode as of now.
Ma'am, is it now?
Just, somehow, at least to me, partly visible. I don't know if
Ma'am, it's perfectly visible at my
perfectly
end.
visible.
Yes.
Okay. Then
Okay.
please carry on, Divya.
Yeah, so thank you so much for welcoming here. It's very nice. And Nancy ma'am has already made amazing grounds for me to present my case. So I am Divya and I am pediatric oncology dietitian working here at PGIMER in APC in PHO unit. And I'll be presenting my case on a child with ALL. So we'll start with the patient's profile. The name AV, age is 8 years, 10 months, and the gender is female. Ethnic background says that she's a Sikh and belongs to a middle income group. Father is a farmer, mother is a housemaker, child itself was in 2nd class, and the habits were vegetarian. So the final diagnosis and treatment, how we proceeded was the child was admitted in APC emergency with a history of weakness for 2 months, majorly in both the legs, fever for 2 months, and the detailed history which came out was with a history of throat pain, blood transfusion that happened on 11 Feb 2023, weight loss, anorexia, blue rashes on both the legs. That was 15 days before the child was admitted to APC emergency. So the current treatment, what started was admitted with biocytopenia with hyperleukocytosis. TLC was 60,000 at the presentation. That was on 9 March 2023. She received 1 plasma red blood cells and 4 platelet cells. Samples taken and sent for PBA fish flow cytometry for the final diagnosis. And the final diagnosis that came up was B-cell acute lymphoblastic leukemia. The course of initial treatment, that was the induction phase. The child was given drugs like allopurinol, prednisolone, IT, methotrexate. And after 35 days of that treatment, the final risk had shifted to high risk. Cycle 1, that was consolidation, which is surely a highly emetogenic regimen. And the drugs included all had nausea and vomiting too much. So the drugs were IT, methotrexate, cyclophosphamide, VCR, vincristine, L-asparginase, 6-mercaptopurine, that is 6-MP, and Septrin. So the child's presentation at OPD for dietary advice. So when the child came to me, what we primarily do is we do the baseline counseling that includes hygiene and misconception regarding the food. A lot of patients from regions like Punjab, Himachal, Haryana, they have a lot of misconception regarding their food. Like if it is cold, so they are not supposed to have, if the child is having cold or cough, they are not supposed to have curd or ghee. Or bananas. So these were the misconceptions, and of course the hygiene part that we included in our baseline counseling. And of course, high caloric and high protein dietary advice and options were given along with the fluid requirement and consumptions, which we explained to them. And then the baseline assessment done. As ma'am has already explained, Nancy ma'am has already explained about the ABC of the diet. So we started with the assessment, and that was recorded basic details of the patient that included the child's name, age, and date of birth, district, state, so that we can have a good overview to what area the child belongs and what dietary, the dietary food or whatever they might be eating and liking. So the anthropometric measures then was done, which included weight to age, height to age, BMI to age, MUAC to age, that is MUAC to age, and the grading was done. So you can see that after every anthropometry, that is weight to age, there is a Z-score that has been given, that is -2 SD for weight, normal for height, BMI, that is -3 SD, and MUAC, -3 SD. So these are the charts that are from WHO, the recommendation from WHO. These are the simplified table, and we follow these table for their assessment, basically to grade them. So as I told, the child was 8 years, 10 months. You can say weight for age, 8 years, 10 months. The child should be lying between 23.6 to approximately 32.9 kgs. So the child was on -2 Z-score. The height was normal as per height for age. Then we have BMI for age, that again stated the child was at the lower side, that is -3 SD. And MUAC that we followed is from A.V. Khadilkar et al. That is taken up from Nutrition Journal 2020. So as girls section, she lied between 9 to 9.10, and we graded her approximately around, if we see MUAC was 16 centimeter. So again, it is falling below the 25th centile that says she is -3 SD, -4, -3 SD. So what instruction at consolidations for the preparation we gave her were high odor food subside. And Nancy ma'am has already explained, because of high emetogenetic side effects of the first phase, that is consolidation, the child might undergo into the nausea status. So we ask the child to avoid high odor food till nausea subside, and of course the parents to avoid giving them high fragrance food or cooking, to be precise. Second, start the child on clear fluids plus denser fluids in small and frequent amount. Example, homemade dense feeds, soups, and of course, like cold diet ma'am had explained about, we also follow the same one, ice cubes, lemon water and ORS for electrolyte correction. It was advises to manage the side effects. Once the liquid is tolerated well, start with semi-solid bland food. Example, mashed potatoes, rice, khichdi, soup with bread chunks, curd, milk, and soy if milk intolerant. So basically, what all we have mentioned in liquid tolerance, after the liquid tolerance, we should try include all the food groups, keeping in mind that the child needs all the micronutrients and macronutrients to build the child's body up and immunity system as well. The dietary goals and of course the requirements stated to ensure the child eating all the food group, as I had already been mentioning about it, the child's acceptance and tolerance towards oral diet, to meet nutritional requirements of the child, to closely monitor the child's anthropometry to improve malnourishment. Requirement for the child as per age. So since I was talking about to meet the nutritional requirement of the child, I will, ma'am had already told about the RDA that we follow. So we have extracted that requirement of the child from that RDA, and that says energy requirement as per RDA, that is 1700 kilocalorie for the child. Protein intake is 19 grams, fat 30 grams, carbohydrate 100 grams, calcium 500 mg, vitamin C 36 mg, and fluid requirement approximately 1.5 liters that we have to give. Sometimes looking at the cancer cachexia, in which a lot of repair and of course the diet is hindered and diet is not taken properly, it's not optimum, we definitely increase the proteins and give it to the child. So for this child, the assessment that I have showed it in an Excel form. So it says the baseline, the child was 21.8 kgs, height was 131 centimeters, and the yellow mark says that it is 12.7 meters square BMI and 16 centimeter of MUAC, that says the child was graded as third degree malnourished. So by weight third, 60, that was 16/5/2023. The weight had increased because the child was on steroids and the eating habits was quite high. She was eating almost everything, and the diet was plus for us. So you can see the growth chart. When the child came to us on 3/5, that is 3rd of May, the child was here at the weight section. It was somewhere between 20 to 22 or 3 in between, and how it raised till 3rd/9, that is 3rd of September. In reference to the weight, BMI, and MUAC, all the parameters are going high by the 9th month. So we'll explain more about it by this formulation. So the first and second visit the child we talk about is 3rd May and 16th May, when the child's weight was also fine, the MUAC was gradually increasing. So the oral intake was quite adequate, and almost 77% of the RDA. The child ate almost 4 chapatis, 1 katori of dal, cooked vegetables, 1 katori, milk 3 times, that was 250 ml into 3 times, and 2 exchanges of fruit banana. If you see, all the exchanges are included in her diet, but we still asked her to increase the pulses and add some sweet and visible fat to the food. Since we can see there was less of pulses taken, we at least want the child should have 2 katoris of dal per day for the protein optimum requirement. and of course something sweet, caloric dense, that will add on to the weight. By 24/7 she came again, and the weight was declined. That was when the child was undergoing the consolidation phase, and in between the child started facing the side effects of chemotherapy and missed follow-ups due to fever, antibiotics, and of course the grade shifted to grade 4. Grade 4 is severely acute malnourished, and it is a red signal, definitely a red signal for us, and an indication towards a nasogastric tube, as ma'am had explained in her algorithm. Oral diet came down to 27% of the RDA. If you see, the child was eating only half a katori of rice per day. Pulses were 1/4, if you can say, just 4 to 5 spoons per day. Milk had come down to 2 glasses. Lemon water was 1 time. And banana was just 1, and that too was in 2 shifts, like half a banana in the morning, half a banana in the evening. And the calorie that the child was having was just 460 kilocalorie, which was enough for us to take a decision for a nasogastric tube. So nasogastric tube was advised due to the change of grade of malnourishment, and the feed plan was explained. That was 83% of the RDA and included 3 feeds of casein feeds with sugar, 2 feeds of sweet homemade buttermilk, which converts like a probiotic for us, 2 feeds of soy feeds, and 3 times oral diet that included food that the child liked. The child definitely wanted to eat, so we definitely put this kind of a chart in front of the child so that there is no compromise with the oral diet as well. So the energy that came up from that diet was 1414 kilocalorie, that met up the 83% of RDA. The instruction for care of nasogastric tubes were given, that is chest head elevation to avoid reflux, 10 ml water pre and post feed to maintain the tube hygiene, since the child might cry, vomit, have episodes of cough and cold, in which the acidic review definitely come as an aspiration. So we asked them to put 10 ml before and after the feeds. And of course, for digestion need, we need a burp of the child. So we asked them either walk or make the child to burp. By visit 7, 9, and 12, that was the 7th month, the 9th month eventually, the weight started gaining. After 7 days of nasogastric tube feeds and oral diet, 1 kg, 100 grams elevation in the weight was observed. However, child started with the episodes of vomiting and pulled out the NGT, that is nasogastric tube. Since child was on interim maintenance phase, that is the bed chemo, hydration, methotrexate, 6 MP, that is mercaptopurine, leucovorin, palanstroin, which is an antiemetic, was given. Oral diet that included chewing was compromised, since methotrexate has impact and can cause mucositis and nausea feeling as well. So the oral diet that included chewing was compromised. However, semi-solids and liquids was easily tolerated by the diet. So we tactfully planned, keeping in mind the side effects, and of course the likes and dislike has always been a priority for us. And we made a plan that included all the likes and dislikes orally given, since the child was really agitated to get an NG inserted again. So the child was advised high protein, high calorie, semi-solids and liquid diet that met 100% of the RDA. 4 feeds of commercial peptide-based supplement, that was 300 scoop in 200 ml of pre-boiled cool water. 4 feeds of sweet buttermilk, since child liked buttermilk. 2 bananas and 1 to 2 servings of high carbohydrate food. 1 serving of khichdi and fries, pakoda, soya nuggets to her likes. ORS with lemon for electrolyte corrections was advised in case of nausea and vomiting. By visit 9th and 10th, that is 5th, 9, 2023, the 24-hour recall was tremendously improved. Oral diet included milk 3 times with commercial supplement that was advised later on, and it was a whole nutrition. Stuffed parathas 2 to 3, cup of 2 cup of curds, chapati or puri. Puri is a like fried chapati. 2 to 3 in lunch, pulses, 1 cup pakora. Then rice, 2 medium bowls in dinner, pulses, 1 cup plus vegetable soup to include our vegetables as well. Boiled potatoes, 2 plus fries plus buttermilk 2 times a day. The child improved tremendously. And you can say that the child's weight 29.9 was 26.4, which was approximately 6 kg, 200 grams of elevation since the child had deteriorated on 24/7. The take home definitely says that please, it is very important to understand the likes and dislikes of the patient. And of course, we need to work together, and the timely follow-up by the patient is mandatory for us to make impact in their nutrition actually. Yeah, thank you.
Thank you, Divya, for a very nice presentation and overview. So I can see a couple of questions in the chat box. One question is, will buttermilk and fermented food increase nutrient absorption? So would you or Dr. Nancy like to comment on this?
See, buttermilk and fermented foods, definitely the bioavailability of nutrients is improved. So, you know, the B complex, vitamin C, so all this is improved. And the probiotics. Probiotics is a positive thing. The gut microbiome, the healthy gut microbiome is very important. So this is a positive nutrient for all the patients as well as all the normal persons. Yeah.
Right. So fermented food, once cooked, are safe for consumption even in oncology, and they're, like you said, very nutrient dense.
Yeah. Yeah.
So they are a very good thing to take. There is another question regarding GVHD diet. Would either of you like to comment on that? So GVHD, it's basically graft versus host disease, which happens post hematopoietic stem cell transplant. And I'm sure the person who's posted this means GVHD affecting gut. So GVHD gut patient, what diet should be advised? Would you like to comment, or
GVHD. Divya?
so
Yeah.
yeah,
So
so
we have a few patients, those who are coming with the same situation when they are having their transplant. After transplant, we see patients going into diarrhea, vomiting situations. So we definitely ask them for a couple of days if it improves. So we ask them to have a lighter, low residue food. Low residue food as in like clear fluids. It can be soups, it can be coconut water, it can be ORS to help their nausea feeling if they are having it. Low residue food will definitely cause the end residue of the product will be not causing trouble to the gut, which is already compromised because of the transplant. So if it is not still tolerable, then we definitely go for a nasogastric feeding. And directly, if it is not orally taken, we try it by nasogastric feeding. So clear fluids,
right.
low residue foods.
Yeah, it can be like chicken also, or you know, it can be scrambled eggs or something like that also. So it is low residue, and it can, I mean, you can add good protein also in that, like this. Yeah.
So when somebody has a gut GVHD, the things to remember are most likely a patient who has had a gut GVHD would have been on TPN to start with. And once we are transitioning from TPN to enteral nutrition, it is important to give smaller volumes to start with. We start with some liquids. Typically, we have to take care of that they are not we still have to take care of the neutropenic precautions in these foods. So calorie dense foods, low fiber foods, as you both mentioned that they should be low fiber foods. That is what we have to give till symptoms improve. And then we slowly reintroduce higher fiber foods going gradually. So basically, we have to make sure that we are including foods and fluids which are high in protein, high in energy to help the recovery, along with being low in fiber. So smoothies are a great thing to take at that point of time. Regular weight monitoring, diet modification accordingly, and neutropenic diet precautions are typically taken in patients who are post-transplant and have gut GVHD most of the times. So I hope that answers the question on GVHD. So if there are any other questions, and if anybody wants to share an experience on enteral nutrition, NG tube insertion, so they're most welcome to do so. So a child with medulloblastoma does not like vegetables at all. We tried to add with other food, but still not tolerating. So I think this is not restricted to medulloblastoma. A lot of children just do not like vegetables. Dr. Nancy, would you like to come? So of course, their children do not like to longer aversion because their taste buds are totally gone. So I don't know if you can, your connection is probably unstable. Dr. Nancy, Divya, would either of you like to answer this?
Connection is too unstable. So, the vegetables definitely, yeah, even the adults are so choosy about the vegetables, But the thing is, vegetables in any form, for example, you make a carrot halwa or a carrot kheer or a bottle gourd kheer. So we have to see how to incorporate. But definitely, if the vegetable has got micronutrients and fiber. So if the child likes anything alternative thing or any fruits or a few vegetables and which can be made in a different way, so what I mentioned, so that will be good. That is good enough. You can ignore a bit of these things, but if the child is having cereals and pulses and fruits and other things, then of course, if the child is having milk and milk products or fermented foods, then it is fine. You can just incorporate a wee bit here and there, because we have to actually, practically speaking, theory, it is very, very easy. As I already told you, to say ki, eat this, eat that, it is very important. But practically speaking, these things are very difficult, and with kids especially. So you just have to camouflage the vegetables and give in their favorite dishes. This is what you can do. Even if, for example, noodles with vegetables or pasta with vegetables, that is also fine if the child is ready to take it.
Right. So I think they're also saying that the child is on NGT. So at times we advise soups through NGT, vegetable soups can be given through NGT, and to make them calorie dense, you can add butter, etc. at times.
I would like to add one more thing is that as a parent, everybody wants to give all the vegetables at one go. We need to understand we cannot incorporate all the vegetables.
Yes.
So we can pick up one specific vegetable that a child likes, and we can add that vegetable to their, soup or khichdi feed. And it's always like we are already giving fluids. So what we can do is, when we are making the paste for that fluid, we can use the products that can easily, being mashed. And then we can extract that vitamin in the water by boiling and everything, and then can be given. So when we are an NG tube, so the soup's extraction soup can be taken vegetable extract that way. So we don't need to pick only one or two. We can, pick up one vegetable that a child likes and then introduce that vegetable to the child.
Right. So thank you, Divya and Dr. Nancy. Another thing to remember here is that this child has an underlying medulloblastoma. So typically the medulloblastoma chemotherapy and radiation lasts for a period of something like 6 to 8 months at the most. So our goal during these 6 to 8 months is to maintain the weight so that the child does not develop acute undernutrition, which would predispose the child to more infections. The child is able to manage his mucositis or his diarrhea if he's having. So 6 to 8 months of trying alternative stuff, just giving the child whatever the child can tolerate, and maybe not stress too much upon the foods they do not like. We can probably just let it slide. So that would be my take on the situation.
Good evening, ma'am.
Hi, good to see you here, Dr. Siaram.
Yes, yes, ma'am. So our main query is the how to convince the parent for the NG tube insertion.
So,
they can
right,
do.
right. That's a issue definitely in oncology, Siaram, because I think finally it's easier to start doing it in people who are more open to it or whose children kind of like are having more issues. People who are borderline may not agree very easily, especially if it is the norm. It is not a norm in the unit already, because it's easy once the norm has been established. It is very easy to convince because people see their like other patients having an NG, improving on NG, but starting it upfront, starting the NG upfront, definitely convincing the parents is not super easy. Finally, like more diarrhea, etc., more intolerance, those children can probably be initially put in the ward itself.
Yes,
And while transitioning from TPN, or children who have NEC and are improving, they will already be on NGT. So rather than removing those NGT, you can kind of just let the NGT be in those children, and the parents will themselves see that like once the NGT is in, the child is comfortable and they're able to take the feed. So what you're asking is, I think, how to start this whole, how to start this thing in the unit, basically.
yes, ma'am.
Yeah, so that is probably one way to do it. The children who are already on NGT for some reason or the other, retain it. Another good way is that you just put the NGT in while the child is sedated rather than in an awake child after talking to the parents. So
Yes,
that is like while an intrathecal is being done or a marrow is being done. So that like the child does not have pain, does not feel it. And but it's like it does take some time and some counseling, like try to keep it for a week or 10 days and tell the parents that we will reassess and take it out if you're still unhappy about it, but
Yes,
it's essential. So maybe that can be tried. So I think this will be the last question that I'm taking. One question, this last question: after methotrexate chemotherapy, the child was coming with complaints of mucositis. What do we have to do to reduce this complication? So right, so methotrexate can cause mucositis, yes, and eventually leucovorin fluids help prevent mucositis. To treat the mucositis, once it is developed, we have to give topical as well as like topical analgesia. If topical analgesia like Dologel or Mucain gel does not work, then the child needs to be admitted for systemic analgesia. If the mucositis is so bad that the child's intake is being affected, there is drooling of saliva, etc., at that time the children typically need morphine infusion. So that is how mucositis is managed. If further courses of methotrexate are required, then we have to kind of the doctor will have to stand at the bedside and decide whether all the like the 100% of the dose has to be given the next time or any dose reduction is required, depending on the severity of the mucositis and the other side effects that methotrexate has caused. So how to manage typhlitis? I suppose you mean neutropenic enterocolitis? So for neutropenic enterocolitis or gut infection, severe gut infection in a neutropenic child, typically the child will be put NPO with continuous Ryle's tube aspiration. And IV antibiotics, broad spectrum antibiotic are given. Directed antibiotics can be given if we have some specific infection. If the child, we are confused whether the child or there is a possibility of Clostridium difficile, then we cover for that with either oral vancomycin or oral metronidazole. Typically, oral metronidazole is more easily available. So NPO, Rives tube aspiration, absolute gut rest during the period of NEC till the child starts getting hungry, till the Rives tube aspirates improve and the gut overall improves, the diarrhea starts settling and there is like the blood and stool stops. So it's the management and the IV antibiotics. So I think here now we are already a little bit over time. So I'll say thank you very much to everybody for attending and for being so involved in the discussion. Thank you very much to Dr. Nancy and Divya for wonderful presentations, very clear and crisp presentations. And we will see you in the nursing workshop next month at FOCON. And we will probably have the next webinar in December now. We will keep you updated on this in the common WhatsApp group. So thank you, everybody, and goodbye.
Thank you, ma'am.